Good morning, Dr. Harsh.
Good morning, sir.
So today we will be giving you a task. This is a kind of a mini clinical examination test. So I will be assessing you. I will be giving you a clinical sign to demonstrate, and after that we will have a discussion on that particular clinical sign. And today our clinical sign will be palpation of trachea. So here is our subject. You go ahead and examine the trachea.
Good morning. My name is Dr. Harsh. Today I will be going to examine your neck area and your windpipe. May I have the permission, please?
Okay.
Trachea will be palpated by the two techniques. One is the screening method and the second is insinuation method. In the screening method, we will palpate the trachea with the three-finger technique. In this, the neck is in the semi-flexed position. The index and the ring finger is to be placed on the sternoclavicular joint where the sternal head of the sternocleidomastoid muscle is to be attached. Then, with the middle finger, we will palpate the thyroid cartilage. Adam's apple will move above downwards towards the suprasternal notch. Here is the Adam's apple thyroid cartilage, the cricothyroid membrane, the cricoid cartilage, and from the cricoid cartilage we will palpate the trachea towards the suprasternal notch. In this, the trachea is centrally placed. Now, the second method is insinuation method. In the insinuation method, we will insinuate the finger in between the lateral border of the trachea and sternocleidomastoid muscle. Here, we will feel the gap or any resistance in between the trachea and sternocleidomastoid muscle. If you will feel any resistance, then that means the trachea is shifted towards that side. Now we will assess the cricosternal distance. We will palpate the cricoid cartilage and the suprasternal notch. The distance between this is a cricosternal distance. Now we will accommodate the three fingers between them. In the normal person, the three finger will be easily accommodated. In the condition like emphysema, the cricosternal distance will decrease and the three fingers cannot be accommodated between them. Now we will examine for tracheal tug signs. There are two signs. One is Oliver sign and the second is Campbell sign. For examining the Oliver sign, which is mostly seen in aortic arch aneurysm, we have to go toward behind the patient. We have to hyperextend the neck. We have to put the index finger over the cricoid cartilage and we have to pull the cricoid cartilage upward, and we have to feel the systolic arterial pulsation in the cricoid cartilage. In the cases of aortic arch aneurysm, you will feel the pulsation over the index finger. Now the second sign is Campbell sign. You have to put the index finger over the cricoid cartilage. In the conditions like acute exacerbation of COPD and emphysematous lung, the index finger will move downwards with each inspiration.
Good. Dr. Harsh, you have completed your examination, your mini clinical examination. So we have palpated the trachea today. You palpated the trachea. You correctly demonstrated the two methods, that is the screening method and then the finger insinuation method. And secondly, you talked about another important clinical sign, that is the cricosternal distance. How in a normal person, three fingers can be insinuated between the cricoid cartilage and the suprasternal notch. And in cases of, you correctly also identify the cases where COPD, emphysematous hyperinflated chest, the cricosternal distance is reduced. And thirdly, you correctly demonstrated two signs, that is the Campbell sign and Oliver sign, how these signs can be elucidated in cases like aortic arch aneurysm and in COPD with acute exacerbation cases. So can you tell me why this trachea is central? Actually, the trachea is a mediastinal structure. It is midline and or else slightly it is deviated to the right side. maybe slightly deviated to right. So why the trachea is a midline structure and why it is, if at all in a normal person, it's slightly deviated to right? Can you answer?
Sir, normally the bilateral negative pressure, pleural negative pressure, the trachea will be centrally placed.
Okay, very good. So basically it is due to the negative intrapleural pressure, which is around -3 to -5 millimeter of mercury in the both intrapleural space. So because of this negative intrapleural pressure, the trachea is pulled from the either negative intrapleural pressure so that it is maintaining a central structure. Slightly it can be little bit deviated to right, especially is due to the compression of the aorta on the right side, or else it is centrally placed because of bilateral negative intrapleural pressure. Now why it is negative intrapleural pressure? Because those intrapleural pressure which is negative, it is helping to prevent the collapse of the lungs. Okay. So can you tell me conditions where the trachea will be shifted to the opposite side of the pathology?
Sir, in the condition like pleural effusion, pneumothorax, hydropneumothorax, the patient trachea will be shifted to the opposite side.
Exactly, because of on the same grounds what we discussed. In cases of pneumothorax, pleural effusion and hydropneumothorax, these are pleural disorders. So when fluid or air is getting excessively accumulated in the pleural space, the negative intrapleural pressure is now becoming positive towards the atmospheric pressure. In these situations, the opposite negative pleural pressure, intrapleural pressure, is pulling the trachea. So if these pathologies are present in one side, the trachea will be pulled to the opposite side. Very good. Now can you tell me conditions where the trachea is shifted or pulled towards the same side of pathology?
Sir, in condition like fibrosis and lung collapse, the trachea will be shifted towards the same side.
Same side of pathology. Very good. Now there are a lot of lung conditions. Can you enumerate some conditions where the tracheal shift is not affected? The trachea remains central, but the lung is diseased. Tell me some conditions where trachea remains central.
Sir, in the condition like consolidation, interstitial lung disease, COPD, emphysematous lung, the trachea will be in the centrally placed.
Even in conditions like bronchiectasis, bronchial asthma, they do not affect the trachea. So in this mini clinical scenario, when I summarize, the candidate was given the task to palpate the trachea. In the end, we know what are the different methods of palpation of trachea. Never forget to go for the cricosternal distance and never forget for the tugging sign. If asked in the viva voice, you should know what is tracheal tug. And we should know the conditions where the trachea is shifted to the opposite side of the lesion and the conditions where the trachea is shifted to the same side of lesion. Thank you.